Hello, I'm Dave Little, CEO of Scottish Drugs Forum, and I will be chairing today's webinar, which is scheduled to run until 2:30. The webinar will finish after the last scheduled speaker. Scottish Drugs Forum are hosting this event with the Drug Death Task Force and its medication-assisted treatment subgroup. Today, we launched the consultation on the implementation of the new MAT standards. The consultation will last till the end of January. Draft standards were published earlier this week, and everyone attending today has been emailed a copy. A copy will also be posted as a handout you can access during this event. The development of the MAT standards and their implementation are a significant step in improving Scotland's response to problem drug use and addressing the ongoing public health emergency of drug-related deaths. In SDS view, these standards represent the most significant development in responding to problem drug use for more than a decade. Successful implementation of these standards is our best hope of addressing our public health emergency. Central to that achievement and central to these standards is a transformation in the way that services are able to engage and relate to people they seek to serve. Reducing harms and improving lives is rooted in the values reflected in these standards: dignity and respect, rights, empowerment, and choice. We need leadership and determination and resources to allow services to operate from these values and to be driven by feedback they receive from their key stakeholders, the people who use their services. One key issue across Scotland is that we have such a low rate of people in treatment. Implementing these standards will make it easier to get into and stay in treatment, and they will also make treatment a more attractive offer to people. We will hear today about progress already being made around implementation of the standards, for example, around same-day access to treatment, choice in prescribing options, and assertive outreach to ensure people can get into treatment and stay in treatment. We have an impressive range of speakers today. Firstly, we have Joe Fitzpatrick, Scotland's Minister for Public Health and Sport and Wellbeing. He will be followed by a video of people with current living experience of being on medication-assisted treatment. Then we have a joint presentation from Duncan Mccormack, Chair of the MAT subgroup of the Drug Death Task Force, and Eleanor Dickey, who's MAT Programme Lead at Public Health Scotland. This will be followed by two presentations on quality improvement, already undertaken as tests of change funded through the task force. The presentations will be from Tracy Klusker, the Drug Death Task Force MAT Clinical Lead, who has recorded her presentation, and Kate Ainsley, Community Addiction Nurse in NHS Borders. We will then conclude with two presentations that will describe wider work and perspectives on the standards from Lothian and Glasgow, from Mike Keogh, Clinical Director Addictions with NHS Lothian, and Saket Priyadashi, Associate Medical Director of the Glasgow Alcohol and Drug Recovery Services. These sessions will conclude with a summary of the various ways people can engage in the consultation. You can submit questions as part of this webinar, and we encourage you to do so throughout the webinar. Although there isn't a question and answer session as part of today's launch, we will endeavour to respond to the answers or refer you to colleagues working on the standards. The questions tab appears on the control panel, which should be on the right side of your screen. So, to the speakers. We are delighted to have the Minister to launch the consultation on the standards today, and I'd like to hand over to Joe Fitzpatrick. Thank you, Joe.
Thanks very much for the introduction, Dave. I'm very happy to be here today to be able to launch the consultation into the standards on behalf of the Scottish Government, but also the Drug Death Task Force. Medication-assisted treatment, or MAT, we know is an effective and proven treatment for opioid use disorder, and also one which we know reduces the risk of death for people who use drugs. However, despite its proven success, there remains in Scotland an inconsistency in how individuals can access the support that they need. This has certainly been the case in terms of the choice of medicines made available to people, but even more so with regards to the psychological support which is available in order to help people manage issues of trauma and anxiety. That's why I'm so delighted to see this work on the development of these 10 MAT standards reaching this crucial point. The need for a MAT pathway or a set of national standards had been identified before the setup of the Drug Death Task Force. However, the task force, and specifically the subgroup which has led on the development of these standards, have prioritised this work, recognising that getting more people onto MAT more quickly and supporting them in treatment for as long as they need is an effective method of reducing harms and promoting recovery. The standards themselves are a mix of those which will centre on how service delivery can be developed, looking at access and choice and how service systems can be developed, focusing on care and support. However, for me, the most important point about these standards are that they place the person right at the centre of the decisions being made about their care and treatment, and that they acknowledge the wider issues such as trauma, which features in 2 of the 10 standards. And they're clear in their expectation that services should operate a policy of no barriers to access treatment. The standards also offer people choice, something which for many has been missing when they've tried to access MAT in the past. Whether that's the choice to start treatment on the day of presentation, the choice of medication which they choose to use, or that those with co-occurring drug use and mental health difficulties can choose to receive mental health care at the point of MAT delivery. These are small but hugely important changes, and ones which will make a big difference in the way that MAT is delivered. Furthermore, the standards will provide a level of consistency which hasn't been seen before. As highlighted in the foreword to the consultation, it's vital for us to move towards a national approach which will ensure a consistent service can be offered and made available to access all over Scotland. These standards move us significantly closer to that position as they define what is needed for the consistent delivery of no barrier MAT. You'll hear more later this afternoon about some of the early progress and some of the local initiatives which these standards have already led to, but I just wanted to mention one example. While rightly the focus around the development of the standards has been on those accessing services, the standards will also allow for clinicians and others to make radical changes to their working practices, meaning that they can treat many more people than previously possible. And this was emphasised in a blog post on the Drug Death Task Force website by Dr. Joe Tay. So Dr. Tay had undertaken a test of change in his service to demonstrate the impact on people when working with a low threshold model. He highlighted how these new standards gave him the permission to say yes when people came to him seeking immediate help, something which he hadn't been able to do previously. As a result of the 35 people who came to his service in the 2 months in which the test was running, 93% received the treatment they wanted within 24 hours. Furthermore, nearly all of them had additional needs that they had not been able to deal with until after treatment had been stabilised. And that included issues such as food poverty, accessing benefits, homelessness and depression, all of which were able to be addressed at roughly the same time as MAT was initiated, on the day that they came for help. That's fantastic progress and something that I hope we can see replicated in services all over the country. So thanks so much to Dr. Tay for that trial and showing what can be achieved. I'm also delighted to see that the first page of the consultation document is a foreword from people with lived and living experience of substance use who've been involved in this work from the beginning. The value of those with lived and living experience shouldn't be underestimated, and it has been enlightening for me to sit in meetings with those who are able to share their own personal experience of the issues being discussed. This value comes through in the foreword to the consultation, where Becky, Colin and Alan refer to the responsibility that they feel as members of the task force to ensure that every avenue is explored, that the range of options is wide and daring, and that there is an option at the right time in the right circumstances for the right person. When you look at the 10 standards which have been developed, it's clear to me that not only have they spoken up for what they feel should be the rights of those accessing MAT, but that their voices have been heard and listened to. It's vital that we focus on the real experiences of real people using services to understand where we are and what changes are required and what changes we can make. And I very much hope that through this consultation process, we can hear from many more people about the differences that these standards could mean for in their treatment, of themselves or their loved ones. So I think that's probably more than enough from me this afternoon. So I just want to finish by placing on record my sincere thanks to all of those who've been involved in the development of the standards to date. That includes all of those on the Drug Death Task Force and the MAT subgroup, but also those who've helped to shape the standards, working with the subgroup and engaging at an early point in this work. And finally, I want to make a plea and encourage all of those with an interest, whether that be because you work in harm reduction, prescribing or outreach, whether you're currently in treatment yourself or know someone who is, that you take part in this important consultation on these standards, and let us hear your views. And I'm certain that we'll be able to make a real difference for so many people across the country. So thank you very much, and I look forward to listening to the discussion going forward. Thank you.
Thank you, Minister. Sorry, I didn't mean to come in so quickly there. I jumped the gun slightly, but thanks very much, Minister. And it's vital there is leadership at a high level for these standards, and you've certainly shown that, Minister. You also mentioned the importance of hearing the voices of people with lived and living experience, and that leads us neatly on to our next presentation, which is a short video of people who are currently in medication-assisted treatment. I am grateful for my colleague Jason Wallace for putting this together. So now we'll watch the short video. Thank you.
I think it's a great thing for the simple reason being, right, if they tell somebody you can maybe come back in a couple of weeks and we'll get you started on methadone or something like that. In a couple of weeks' time, the guys might have changed their mind. They might be in a totally different place altogether mentally. And the other thing is, they could by that time they could be dead, because that's how serious it is, this problem. You know what I mean? People are dying all the time with drugs, and I just think it's a great thing. I think it's a great standard to put in place.
From my own experience in addiction, you have a very small window of opportunity when you want to change your life. So if you go along to some sort of service for addiction and say it's a frontline service, like, you know, methadone prescribing or whatever, and you go there that day, you really want your life to change that day. It's got so bad that you want to change that day, you know what I mean? And to be told you'll need to come back in 3 weeks when you don't actually know where you're going to be in 3 weeks or how you're going to be in 3 weeks, if you're still going to be living in 3 weeks, because things might be so bad that you just need to desperately change your life that day. And from my own experience, sometimes when I've not been able to access that treatment, that service or whatever, it can take, you know, 6 years before I rotate back round to deciding I want to change my life again. I mean, I was a lucky one. Obviously, there's other people behind me and in front of me that never rotated back round, you know what I mean, who died out there, and died as a result of they couldn't come back for 3 weeks. They couldn't come into a doctor's surgery and sit there, you know, and just keep up with them appointments or whatever for 3 weeks. So I think it's vital.
I think this is a brilliant thing. I think this should have been brought out about a good few years ago, when things were at a crisis. Well, it's even more at a crisis now.
I think it'd be a great thing for people to have that choice, especially if I think Buvidal is a great thing, because I mean, you don't feel trapped to a chemist. You just go and you get an injection once a month, and it's like an oily capsule put under your skin, and it lasts over a month, and then you get another injection. So you feel as though you can live, you're able to live your life then. Do you know what I mean? Without feeling as though you've got to go to a chemist every day. You're feeling as though you're kind of people look down on you. But I mean, there is people who will probably want to still stay on methadone. I would rather be the one who's more involved in saying what I feel is best for me. You know what I mean? Because sometimes people come into it and they think they know what's best for you, but I think every individual knows what's best for them. For me, it would have probably been something different rather than methadone. But I would have definitely liked to have had my own input and my own choice about how my treatment goes, you know.
I think that's a good idea where they could go into the services and say, well, I don't really want to go on that methadone. I've heard too many stories about that methadone. What about this and what about that? And then teach, well, not teach them, but let them know what each drug consists of. And how it works and things like that. So I think it's a great thing that they are now getting a choice of what medication that they want to go on.
The most important part of that phrase is informed choice for me, because in my own experience, I've made a lot of ill-informed choices based around opiate replacement, basically therapy. You know, I believed a lot of myths in the past, and I made mistakes because of that, and mistakes that cost me a lot of time, a lot of pain, and possibly a chance at recovery. So, you know, communication and about choice and all that, I think it's a great idea, definitely.
I was reasonably lucky. I had a great key worker who phoned me every week just to make sure things were okay and how my mood was and blah, blah, blah. And that doesn't happen often enough now. That one phone call could save their life. One phone call or one text even, just to let that person know that they are getting thought about. Because I know that I looked forward to them phone calls when we were in lockdown. My key worker was amazing and would have done anything for me through lockdown. So I know that that could be done.
I personally benefited for getting contacted every week in some form. My preference would have been to go in and have an appointment, but it didn't even matter what stage I was at. If I got contacted every week, I seemed to respect the sort of service more, or value the service more, or, or maybe give more of myself over, you know what I mean, to my recovery sort of thing. I don't know. I just felt more involved, and obviously it will save lives as well for anybody who's sort of went back the way, or started using again, or is in a difficult situation, maybe life threatening. That call could maybe save their life or get them some support that they really need at that point. So it's a great idea for me, definitely.
A lot of people can get so chaotic in their life that they don't accept the services, or they just can't accept the services. Their lives just became so chaotic that they can't seem to get anywhere. So if somebody was to follow up on that, phone them, contact them in some way, and try and get them back into a stable environment or a stable kind of situation, then I think that's a good thing. That's definitely a good thing.
I think it's a great idea, basically. It sounds like it would save lives to me, because if you're accessing services and you're wanting to change your life, that doesn't mean that everybody around you wants to change your life as well. So you could still be associating with people who are in active addiction or whatever, and you might be in a situation one day where naloxone is needed. You know what I mean? Where you're in that emergency situation, somebody's dying in front of you. You know what I mean? ODing, and because you've got that naloxone, or because you've got access to it, they might survive that day. So that's a life saved. The other one is, you know, you have bumps in the road. I had bumps in the road. I went back to it a few times, and having clean equipment is probably one of the reasons why I'm still alive today. You know what I mean? And why I haven't got some of the bloodborne viruses that that come with using dirty equipment, you know what I mean? So it saves lives, and it sounds like complete common sense to me, aye.
Well, you get a lot of the ones that say, right, you've been on treatment long enough, I think we're going to start cutting you down now, or we're going to put you up because I don't think they're doing too well. And at the end of the day, they're maybe only seeing you once a week, and these days they're probably only seeing, they're not seeing you at all. They're talking to you on the phone, right? So I don't know how anybody who isn't living with you every minute of the day can try to turn around and tell you, listen, your time's up, or you need to start going up in methadone, or you need to start coming down. I think that should be your own decision.
Before lockdown, I had said to my worker, look, I'm not ready to come off of methadone. I says, and I don't think I'll be ready for a long time. I says, I'm now using my methadone as a pain med. I says, I don't know how you think about me being on that long term. She says, look, Sylvia, if it's going to help you, there's no way I'm going to take you off it. If that's what you want and you're happy with that at the moment, that's fine. So I got that option. So I would like to think that other people would get that option to stay on it. I don't think there should be a time limit on how long you're on treatment.
Again, it sounds sort of simple common sense, doesn't it? Engage in treatment for as long as you need that treatment, you know what I mean? Because the alternative, in my experience, is, you know, jails or death or hospitals or, you know, serious consequences, you know what I mean? So if you need that treatment, then you should have access to it for as long as you need that treatment, you know what I mean?
I can't see any kind of any negative sides of it. If the person themselves gain more power in their recovery, I think that can only be a good thing.
There is no negatives, definitely no negatives on it. The only way we'll find out if this will work is when we do start, when it does get started. But I can't see it not working. To be able to go in and access the services that day and come out with a prescription that day, that's amazing, and that's what we've been trying to do for a long time, and I'm glad that's now starting.
I would say they were quite positive. I've definitely benefited by some of the standards elsewhere, you know, or similar sort of stuff. I don't know if they were actual standards of care down there, but I've managed to get prescribed within 24 hours. You know what I mean? I've managed to have it for as long as I need it. You know, I've been consulted on what I wanted to do, you know, and stuff like that. And maybe that's the reason why I'm still alive. I don't know. You know what I mean? Like, you just never know. But I imagine that this will help save some lives. You know, that would be the hope anyway.
I think you'll agree there are some really powerful messages in there as to why the standards are so important and why we need to effectively implement them. We'll now hear from two people who have been working tirelessly to get to this point in terms of the standards. I'd now like to ask Duncan Mccormack and Eleanor Dickey to present. Thank you.
Hello, thanks very much, Dave. I'm Eleanor Dickey, based at Public Health Scotland, and I'm the MAP programme lead in the drugs team there. It's great to be here with you today.
I'm Duncan Mccormack. I'm a public health consultant at NHS Lothian, and I'm working closely with Eleanor and the rest of the team. I also chair the MAP subgroup of the Drug Deaths Task Force.
So we're going to run through some slides just outlining the evidence and the standards, and it's really just to bring the work to you, to demonstrate the progress so far, and really just reflect that this work has been protected as a priority both by the Scottish Government and the Drug Death Task Force, as well as Public Health Scotland. And the phase of the work now is really just to ensure that they can be the best they can be with your input. We've heard that we've got low levels of numbers in treatment. If we move on to the next slide, the nature of the standards is really to bring some improvement and innovation, and we wanted to open and close with this image just to demonstrate the importance that innovation happens in many ways and not to underestimate the small steps. We don't want this work to be out of reach for anybody, anybody concerned in services, anybody delivering services, or anybody experiencing services. And so we just felt it was important to reflect on what the offer is today. We hope that those of you that are way ahead of us will see the standards as a framework to continue to develop your services. And those of you that have seen opportunities for improvement, we hope this will give you the confidence and the permission. If we move to the next slide, the definition of medication-assisted treatment is the use of medications such as opioids, together with the psychological and social supports in the treatment and care of individuals who experience problems with their drug use. And that's really to reflect the holistic nature of a rights-based approach, ensuring that we put the individual at the centre and recognise that we all have different needs and different circumstances. If we move to the next slide, I wanted to pick up from our foreword of the consultation document. We heard from the Minister, our colleagues on the task force, Becky, Alan and Colin. Here we've highlighted that approach around vulnerable people, ensuring their dignity and respect. And I think the video demonstrates that from the other members of the group that have contributed today. And ensuring that we're non-judgmental and we move to a national approach, and that's what the aim is of the standards, is to have consistent delivery, and that no matter where you are in Scotland, you receive a high quality service. And then we're asked to really reflect, how would we like to receive services if it was us or a loved one who was needing to access treatment and support. And the next slide is our foreword from the Chief Medical Officer, the Chief Nursing Officer and the Chief Pharmaceutical Officer at the Scottish Government, that really just identifying this is one element of the task force work and one critical element in our ambitions to prevent drug deaths. I believe we can prevent them. I believe these standards are part of that process. And there has been a focus around opioid dependence. We still know that many of our drug-related deaths have opiates and opioids implicated in them. So the next slide is really just to demonstrate why this work, why is it important, why are we doing it, to bring us back to the evidence. A lot of this will be familiar to many of you, and it's really informed our approach around the standards. This was an evidence review that I conducted in 2017 to inform rights, respect and recovery, and it also draws on the outcomes framework from 2014. Along the top, within treatment, care and support, these are the elements that we know people may present with. So thinking about the psychological and social barriers before even coming to treatment. The first 4 weeks in and out of treatment are critical intervention points. We know that there's an increased risk of deaths, and so it's important to provide intensive support at those times. And throughout the treatment and care that we provide, ensuring that we meet the complex physical and mental health needs of individuals. We know that many people may have had prolonged chronic drug use histories and will have a very complex and multiple physical and mental health needs, and the standards aim to reflect those. Along the bottom, it's the elements from the evidence that we know are effective, things we can do, things we know that will work. Ensuring a choice of medication, which we've heard so far this morning a lot, and thinking about how that can be an informed choice, because different medications will work differently for different people. Reflecting on the therapeutic relationship, we just heard from Sylvia the difference her key worker made in terms of being confident that her treatment plan would not be changed and that it would be what she needed at that time. And broader psychosocial interventions really will motivate and prevent dropout. From the evidence, that's what we know, that the broader needs along with the medication are just as important in terms of improving people's quality of life. So this is just, as I say, to remind us of the evidence that we know that being in treatment is protective against the risk of death. Those in treatment have a reduced risk of less than a third compared to those out of treatment. And that was high level evidence, good quality findings around methadone and buprenorphine, and just recognizing the intensive support that we hope the MAT standards will present. If I can hand over to Duncan now, we're going to walk you through the actual 10 standards. Thanks very much.
Thank you, Eleanor. So as Eleanor says, we know what works, it's clear and it's well evidenced. What we need to do now is implement it. And there are places, many places in Scotland, which are doing a lot of great work, which we just heard from our colleagues in the video. But what is required to make a difference is consistency and a sustained response across all ADPs. And that's why the task force and why the Scottish Director of Public Health asked us to define standards for MAT and to work with ADPs to implement them. So here are the standards, the first 5. The aim of these 10 standards is to get more people safely onto MAT for as long as they need. The first 5 standards we've heard a lot more about today, and that's because these really rely on drug services to take action. So it's a little bit faster, a little bit easier to make progress. The main things are, firstly, there needs to be no barriers to access medication-assisted treatment or MAT. And that means on some occasions, people may well start on the same day, if that is what they need, and if it's suitable to do so. People should be able to choose what drugs they take, what medication they take as part of MAT. It might be methadone, it might be Buprenorphine, which you heard about just now, it could be other things. And that choice needs to be informed. People need support to remain on treatment, and that's particularly the case in the first 4 weeks after starting MAT and the 4 weeks after finishing MAT. But also in between, things happen in people's lives. There's issues with housing, with welfare, the odd pandemic comes along. So we need to plan for these, and drug services really need to anticipate the care needs of the people they're working with, so that people at high risk of non-fatal overdose and fatal overdose have care plans in place so that we can proactively prevent any issues. Harm reduction is a crucial thing, I think. It's anyone who turns up for medication-assisted treatment may still be injecting drugs, and there has to be access to clean needles, syringes, and so on. There has to be access at point of delivery to testing for hepatitis C and HIV. There needs to be access to wound care and other harm reduction measures, again, with no barriers in place, no referrals to other places. It's up to people to choose what kind of MAT experience they have, and it's really up to practitioners to make sure they have easy access to it, that it's safe, and they can support people for as long as they need. If we go to the next slide. Standard 6 to 10, these really rely on complex systems to take effect, so they're going to take longer. And actually in the consultation, you'll find that we're much less developed with these for that very same reason. But here I want to go back to the foreword. One of the comments in the foreword was, how would you wish to be treated if you attended a MAT service? And I think we all want to be treated with kindness, with compassion. We want to be understood. We want to be treated well. And so it's absolutely vital that all services are trauma and psychologically informed, that the staff working in these services are trained and supported to deliver services which meet that criteria. Many people have underlying health conditions, and that is one of the many reasons why shared care with primary care is a really important component of this care package. Many people have lack of good housing, lack of welfare, income, support, advocacy. Again, there should be no barriers to people accessing that kind of support when they attend for or engage with MAT services. Mental health issues, in my experience and the experience of people I've worked with, seems to be one of the most common gaps identified with people experiencing problematic drug use and people providing services. And I think, again, it's absolutely crucial that people attending MAT services have no barriers to access that kind of support as part of the service at the point of care. So that's the standards. It's a work in progress. I need to make that clear. This means that we're working with ADPs to implement these standards, and at the same time, we are consulting on their implementation with as many people who can help us. This is because we can't wait. We need to take action now to prevent drug-related deaths. And somebody who is actually leading our team's implementation work with the ADPs is Tracy. If you go on to the next slide. And she's going to come up on the video in a minute ago, and that actually is her at the top of that ladder, taking little baby steps with ADPs to try and get to success. And I think now we're going to hear from Tracy. So thank you, and thanks, Eleanor.
Thanks very much.
Thanks to both of you. Thanks for that. That's an excellent description of where we are now and where we need to get to. So as Duncan says, our next presentation is a pre-record of from Tracy Klusker. So we'll hear that now. Thanks.
Hi, my name is Tracy Klusker, and I'm here to talk about, following on from Duncan and Eleanor, the work that I've been undertaking on behalf of the Scottish Drugs Task Force to look at the implementation of the MAT standards. And I want to give you some examples of innovation that I've certainly supported and how we want to take the work forward. So why is it important? So with as little as possibly 60% of people in treatment for drug use in Scotland, I think we have to ask ourselves as service providers across Scotland why this is. You know, what are we failing to do? Should we consider that it's not that the people that we are trying to engage are hard to engage, but that actually that some of the services that we're providing are hard for people to engage with? And in terms of moving forward, it's a priority of the task force looking at how we adapt services and our workforce to engage people in service and improve that access to services from around 42% of people engaging to much higher numbers. We know that MAT is protective against drug-related death, so we have to look at how we adapt using the MAT standards as a framework. And what I want to do now is go on and talk about some projects that I've been involved with and supported that have managed to do some innovation around increasing the numbers with a very different style of working with people. So one of the projects that I was involved in, I started 6 months ago in Lothian. This was following the release of the drug-related death figures in Scotland in 2018. And I guess I wanted to understand why, you know, again, so little people were in treatment in the area of the service that I was managing. So I sought out support and was very lucky to shadow Danny Ahmed from Middlesbrough. And so they had a tried and tested model whereby they were starting people on OST on the day of presentation. And really I wanted this standard of care for the people that I was supporting in Lothian. So the project that I'd undertaken was a quality improvement project, and it was based on the ethos of realistic medicine, which is really the spirit of the MAT standards, where the person is at the centre of all the care planning and all the decision making around them. So the initial aim was to understand, as I say, why people are not in treatment and how would I increase these numbers. So the very first starting point for me, the top of this poster, was to actually ask the people who use services or who have used services, ask them what were the barriers, what were putting people off coming into treatment, what did they find difficult about navigating treatment. Some of the feedback that I received was in terms of fixed appointments that were really difficult to attend, lengthy traumatising assessments, whilst they were not in structured treatment, and multiple appointments with multiple people. So the first change that I done was to bring in point of care testing. So when people were arriving looking for OST, or we were seeking people out in the initial, for this project, people were looking for OST, we had almost turned the assessment process upside down. So instead of at one point in Lothian, I think the assessment was over 30 pages long, we changed that to just an assessment that made that safe for us to prescribe for that person on that day. Now that doesn't mean that we didn't take into account all the other needs, but this holistic assessment could be carried out over a period of time, and also given the person choice about who they would want to do that assessment with, who they wanted to share their information with. So the follow-up could be one-to-one nursing, a drop-in style, peer volunteers, smart recovery, and some people really engaged with mutual aid. What I do have to say within the thing that made this such a success in Mid Lothian was the peer volunteers, who really did help and take people along to appointments or take them along to other wraparound care. The outcomes of the assessment is we did change our clinical governance, so it's really important if you're looking at doing an innovation project that you do have clinical governance that keeps the person safe and keeps the prescriber safe. But what we managed to do is reduce our assessment time from 3 appointments to 1. The feedback from people using the service was that the process was less traumatising. From the first cohort that we did involve in this particular test of change, 70% had a previous near fatal overdose. From that, only 1 person continued to have further overdoses, but they did remain in treatment throughout and they were followed up. Everyone accepted the naloxone BBV testing, and it was family inclusive. Only 1 person couldn't be started because they weren't clearly dependent, but subsequently were started, and that gives some assurances that the assessment process was working. And we did manage, if you look at the run chart at the bottom, to reduce our waiting times from 21 days to 0 for people starting OST. And you can see from the run chart there's a huge peak, and that was someone who'd waited 100 days prior to the test of change, who had attended the needle exchange and was clearly using heroin in a very risky way, but it did take us 100 days to follow him up because we were unable to offer him OST at that time due to our governance processes on the day that he presented. In conclusion of this particular project that I worked in, there was no adverse events. 12 months later, all these patients are still doing well. We have not had anyone fall out of treatment. 1 person moved out of area. Some people opted for referral to trauma. We have someone in employment, and I think there was around 5 who went into residential rehab. The service has seen a 60% increase in referrals from the same time the previous year, so that gives some new evidence that low barrier access does make a difference to people accessing services. One of the learning points was that actually, if you're working with people who have near fatal overdoses, the initial model that we had wanted for this particular innovation was really around people still coming into a clinic, and actually what we really needed to do was adapt this further and go to where people are, which we are still in Mid Lothian are still currently again reassessing during COVID times and putting different models of care in place to accommodate that. So I just want to go on now and talk about another project that really demonstrates assertive outreach at its very best. And it was a very exciting project undertaken in response to COVID by Lynn Drysdale, a nurse in Edinburgh Access Practice. Now, she was very aware when the first lockdown came out around in March that there were people who were street begging in Edinburgh who were not in treatment, and their money supply in terms of accessing drugs had been cut. Due to that they weren't allowed to do so due to lockdown and social distancing, and actually a lot of services had closed their doors, so there was a real reduction in people accessing service at a really high need time. So Lynn had looked remotely at how she could do this, and what she'd done in terms of her test of change, she switched to point of care testing and remote access and she actually went out and she went out to graveyards, she went round all the streets and she worked with people where they were at, with follow-up taking place in the Salvation Army, which was a safe place that many people would attend for various other reasons. Her test of change, she offered BBV testing, IEP, naloxone and referral on to other services including BBV treatment. Lynn managed to bring treatment down from 7 days to commencing a prescription on the same day. Now, Lynn, throughout her entire test of change, really talks about the prescription being the start of a treatment process for people, and I would really urge you to go onto the task force website and read Lynn's blog. She gives a really clear understanding about how trauma-informed care needs to be provided throughout every aspect of service delivery, from the first point of meeting someone up to transitioning their care onto someone else. So what can you do as a service provider? So, I would imagine on the webinar today, there's many people who work in treatment services across Scotland, and it's really thinking about your own service and how this fits in. You know, do you have one door to access for people, or is there no wrong door? And a real starting point for myself, and I think for Lynn and the other projects that we've been involved in, is really thinking about your own service and mapping that out. You know, if you think many services, in case people have to call the service, then a letter sent out, and then, you know, it's 2 or 3 appointments, which was the case in Lothian, before someone can be assessed, and they'll receive an appointment for a prescriber who may be a different person from the, you know, the other people that have seen people for triage, for thorough assessment. If someone doesn't turn up, what's the protocol? Do you discharge them? Do you see that as poor engagement, as opposed to the services aren't actually managing to engage people? And I think then it's mapping that as the person who's trying to access the service. If you see it through their lens, do you know, when is it, if it's a telephone call to refer yourself, if someone doesn't have phone, if they don't have credit, do you know, if they don't have an address for a letter to be sent to. Many people will have adverse events in their life. They find relationship building very difficult. So if it's a long assessment and they have to see several people before they start a prescription, that can be very, very difficult. They feel they often have to tell their story to many people. One family member talked about taking their loved one for a prescription, being told to go, you know, with and support them with a drug diary and come back in 2 weeks. And that was absolutely horrific, because they were trying everything to keep their loved one alive, and really a drug diary or this response didn't feel that this was helping save that person's life for them. So it's considering the impact of what your services have and how people access them. And if you just look at all the barriers and what that feels like for the person using the service and how you can reduce them, and if people are working with mental health justice systems, if they are seeing their person, can you have seamless pathways so it's not another referral, not another assessment for someone to start on OST. Next slide, please. So I will just finish up just giving an oversight of the current work. If you've heard about some of the innovation, there are many more projects, and these will be live on the task force website. Now, this is just the projects just now that the task force are supporting in a QI methodology way, and many people across Scotland are now starting to look at different ways of working with people using project charters. We're also looking at a community of practice to learn from each other around some of the near fatal overdose initiatives, how we can share and diffuse that innovation across Scotland. We're also really keen to hear from any service providers who have existing successful practice, so we can map again, share that knowledge and link people up so they can learn from that for their own area. We're very, very keen to hear from anyone across Scotland who would want to be part of a MAT test of change site, and we would support that through QI methodology. And I'm very aware that a lot of the information I've discussed today refers mainly to the use of OST as a starting point for MAT. However, we would like the consideration, we are going to be looking at an expert or steering group around benzodiazepines and the impact that it's having on people accessing services and the impact it's having on drug-related harm and death. And but also are engaging in terms of the overall standards, as I said, with other agencies to look at, working with LPAS, NES, the Royal College of GPs and advocacy projects to ensure that we have input from all the other experts to ensure that holistic care is provided through every aspect of a person's treatment. So I would like to end on that, and my contact details are here if anyone would like to get in touch to discuss any of this or to look at being part of a QI project. Thank you.
Thanks again there to Tracy Klusker, who provided a great overview of Test of Change happening in Midlothian and in Edinburgh. I think we'll also post up as a link the work that she referred to in terms of Lynn Drysdale and that blog. Now we're going to move on to another description of a test of change, and this time it's Kate Ainsley from the Borders Addiction Service. So over to you, Kate.
Hi. I just want to start by thanking you for the opportunity to speak today and really showcase what's happening in the Scottish Borders. I'm sure you can see from my first slide the size of the Scottish Borders. It's a very large area with a relatively small population. Border Addiction Service kind of total caseload at the minute sits around 450. And if you consider that that's kind of scattered around small communities and towns in the Scottish Borders, I'm sure you can appreciate the kind of barriers that we have in providing treatment and care to those in the rural area. Services tend to be distributed around kind of populated areas such as Galashiels and Hawick, and transport links that are quite poor kind of prevent and cause barriers to people accessing treatment. It's worth noting as well, there's no primary care prescribing of opiate substitute therapy currently in the Scottish Borders, which means there's a high reliance upon our service to deliver effective and efficient care and treatment. Traditionally, historically, and actually not that long ago, the wait to access a prescription in the Scottish Borders was around 4 to 6 weeks, and that was a kind of minimum wait. The journey from referral, whether that be a self-referral or a GP referral, to the point in which the individual gets on a prescription of methadone, Buprenorphine, tends to introduce barriers and pitfalls that a lot of people are kind of being missed. And it reduced motivation for people to get into treatment and to stay in treatment. The complex pathway and the negative perceptions that surrounded our team at the time was thought to really contribute to the significant DNA rate that we had. And when you consider all this in relation to the kind of rise in the number of Scottish drug-related deaths, our service felt it was time to act and time to make change. Eyemouth in particular, which you should see in the top right-hand corner of the map there, is a particularly isolated community on account of its geographical location, disadvantaged in terms of resources and support services available to individuals affected by substance use. And to put it into context, it's around an 85-mile round trip to Galashiels, where our base office is. Next slide, please. In 2018, we launched a service evaluation which really confirmed what we thought as a team to be happening. There was a real need for greater flexibility and availability within services in Eyemouth. Service user feedback drew attention to the environment in which care and treatment was being offered. And it always amazes me that I've got an understanding the guys we support really struggle to engage in primary care services, yet most of our clinics are held in GP practices where people often feel stigmatised and discriminated attending. Nearly half of all appointments in Eyemouth at the time of the service evaluation were being not attended. People believed that their wait to get on a prescription was unfair and really quite difficult at times. 70% of the guys that we were supporting didn't feel like care and treatment really met their lifestyle and their needs. And there was an overall lack of knowledge from the guys that we were working with about the services outweigh that of BAS. So services such as We Are With You, Action for Children, the support workers that we were able to offer, and also psychology services that were underpinned within our service. Anecdotal accounts from guys that we were supporting were and kind of experiences of punitive practice that centred the prescription, experiences or reports of prescriptions being halved and stopped on account of continued substance use or poor attendance. There was perceived power imbalances really between the staff that were working with in BAS and the guys that were accessing the prescribing. Often people felt that they had to jump through hoops just to remain on the prescription. And again, these were really reinforced by the environment in which we were meeting people. Next slide, please. So in 2019, the Eyemouth drop-in was developed to more effectively and efficiently and realistically meet the needs of the Eyemouth community. It brought together NHS, council and voluntary sector staff all under one roof and removed the need for an appointment. We met weekly in the Eyemouth church, and there'd been a real discussion about where the best venue would be to have the drop-in. And after a few discreet discussions between myself and Fiona and a very open-minded minister, it was thought that the Eyemouth church would be a neutral building that was well known in Eyemouth, central and accessible to the whole community. Practice moved away from the formal clinical setting to a shared space that really promoted flexibility and inclusiveness. There was greater focus on multidisciplinary teamwork and to offer Eyemouth more rapid access to early interventions and create more opportunities for people to participate in their own care and treatment. The pathway to treatment was simplified and allowed individuals to take control. They could turn up when they wanted, and they were turning up because they wanted, not because they had to. And if someone decided on one day that they wanted to make a change and stop using substances or try and get support, they could do. The trauma-informed low-threshold prescribing guidelines have allowed us to significantly reduce the time to access a prescription, with some individuals commencing a prescription of Esprinol on the same day that they attend for assessment. People are actively encouraged to share the running, share ideas in the running, or being involved in the running of the drop-in. And this has really promoted joint ownership and responsibility. The aim ultimately was to remove all barriers and make treatment more realistic as opposed to a tokenistic tick box exercise and specific to individual need. Real attention has been paid to reinforcing and strengthening therapeutic relationships and trust among those that are accessing treatment and support. And this in itself has really facilitated some really open, honest discussions about use, about risk that comes with no repercussions. And through that, there's been greater development harm reduction support. This improves greater access to sterile injecting drug equipment. Previously, before the drop-in, there was the one pharmacy in Eyemouth where people could access to get injecting equipment, and this is the same pharmacy that people will go in to get their prescription. People would often know people that work there or know people that were visiting the pharmacy, and this really prevented them from accessing the pharmacy. So with the support of We Are With You, we're now able to offer another domain where we can provide actually more varied kind of injection equipment. Because people are attending the drop-in for a much longer period of time than kind of traditional appointments previous, there's greater capacity for blood-borne virus testing, overdose awareness training, naloxone distribution and education, and actually encouraging other partners in health to kind of join us means that people now have access to things like sexual health. The next slide. All in all, the drop-in has become so much more. It's now an integral support to people on a weekly basis, and some people attend purely as on a social aspect, and that's totally fine. They haven't got to necessarily sit and talk about their drug use or their prescription. If they're attending, we're able to cast an eye over them and make sure that they are safe. The holistic approach now means that individuals have choice, and they're empowered to decide how and when they access treatment. There's a huge emphasis on social prescribing. People are able to access haircuts, complementary therapy, psychology taster sessions, and all planned activities are really centred on individual interest and passion. We sit down every week and have lunch together and numerous cups of tea and coffee, and there's something really human about being able to do that and just have general chit chat. It breaks barriers and really encourages, again, the formation of those connections and therapeutic relationships. People that were accessing the drop-in told us that they felt stigmatised and discriminated accessing community fridges and food banks, and people in the local community had made comments such as, oh, if you can afford to buy your drugs, you should be able to buy your food. And taking that on board, we were able to work with local food distributors and encourage them that they have donated food that's nearing best before dates that people can come and access and take home with them from the drop-in should they be struggling. Ultimately, it brings people together from different backgrounds with different experiences, whether someone be using chaotically or it's a loved one and a carer. And there's been some absolutely lovely experiences and people sharing stories that have kind of led people to reflect on different perspectives. There's been numerous celebrations as well. It seems to be any kind of opportunity, there's cake and whatnot. So next slide, please. Attendance to date, so at the end of February, beginning of March, before obviously the pandemic struck, we were kind of getting attendance of around 20 plus people a week in Eyemouth. The average wait for now in the service is around 6 days, with 44% of people getting on a prescription the day that they attend for their initial assessment. 77% of people are on a prescription within 7 days, and our DNA rate is now reduced to 16%. And if you compare these figures to what I spoke about earlier, it's been a huge shift, and it can't all be owed to the Eyemouth drop-in. We've got a similar drop-in in Galashiels now and Hawick that are kind of developed using the same model. And it's also been greatly facilitated by the fact that we have got 6 non-medical prescribers in the team that are able to work very flexibly and kind of run and head up the drop-ins. Today, BAS is reaching around 75% of the drug using population within the Scottish Borders, and that's up from 66% in 2019, and I believe that the national average is around 60%. If I think of case studies in particular, there's one gentleman that kind of springs to mind, 50-plus-year-old, who had a diagnosis of paranoid schizophrenia, who had never accessed treatment before through fear that some of his other prescribed medications for mental health problems would have been stopped. And he came along with a friend and was able to kind of suss the staff out and see what we're all about. And I think it was either week 2 or week 3 kind of informed us that he'd been injecting heroin and using alcohol for the past 10 years. And he was put onto a prescription within 7 days. We were able to engage his CPN in discussions and really demonstrate some really good joint work and to allow him to feel more supported and in control of his own treatment. Again, also as stressful as it's been, COVID has really highlighted the achievements of the eye-mouth drop-ins and the other drop-ins, and that actually because of the connections and the relationships that we've got with our caseload, we were able to really establish those that were of the highest risk and needed the most support during lockdown. And if you go on to the next slide, which I think is the most important, it really highlights some of the comments that the guys have made, the guys who are attending the eye-mouth drop-in and what it really means to them. And this is what really matters to us. And look, I could go on all day talking about eye-mouth, and unfortunately I've been given 10 minutes. So on the next slide, I've put contact details for myself and my manager, Fiona Nichol. And if anybody wants to get in contact to learn more about what we do in the Scottish Borders and how we've done it, we'd be more than happy to hear from you. Thank you.
Thank you so much, Kate. That was great and a very impressive piece of local work. We'll now move on to our last 2 speakers who will describe wider work and perspectives on the standards from Lothian and Glasgow. Firstly, we'll hear from Mike Keogh to give a Lothian-wide perspective. Thanks, Mike.
Thank you, Dave. I'm Mike Keogh, consultant in Lothian, and I'm glad to be able to contribute today. The standards in the virtual forum certainly contributed into loads of engagement, which is a great starting point for the implementation. So I've been asked to give my perspective on the implementation of the standards, it's local progress that has been made, and maybe some of the challenges we'd like to face as we go on. The starting point is obviously to express optimism related to ensuring that best evidence treatment and care are available to all and in a timely manner. And the aim is to reduce drug deaths and harms. So there's loads to be positive about within the standards. Yeah, so as been presented, we're talking about quick access to assessment, to diagnosis, and to medication treatment. We're talking about removal of barriers and unnecessary steps in the journey. We're talking about a standardized approach to identifying and finding people at risk. We're talking about informed, shared decision-making on the full range of medication options available. And we want to achieve the full protective benefit of ORT that comes with retention and treatment, and offering the appropriate support around this. So in Lothian, I imagine like everywhere else, what we do and how individuals get help, it's not uniform. So some of the standards will involve consolidating practice and interventions that are already established, but we still need shared learning with local tweaks depending on the local needs. Some aspects of some standards may need entirely new ways of doing things, and patients need to be at the centre of this. A recent example, actually my current trainee has highlighted, was identified from speaking to patients who'd been in treatment a while, but had changed medication to receiving long-acting buprenorphine injection. And we got consistent feedback that they were doing great, they liked the treatment, but they were done with going to a chemist, and they enjoyed the monthly clinic they were in, where other support was available as well, and they wanted that to continue. That was the model, and we want and need to respect and build capacity to do that. For other standards, service development and redesign will need to take place, and patient perspective and input to co-create something which works and avoids building anything clinically unhelpful or duplicates that which is already available. We know our patients face discrimination and they're stigmatized throughout the health and social care system, wherever, whenever they access it. It's very easy to regard all of someone's presentation as being drug related and dismiss or fail to understand the pressures they are under and their other comorbidities that they have. The things that can help and the sort of things that can be positive are omitted. So I hope the standards throw some light on some of the subtleties of care and treatment for people who use drugs. There's optimism that we can expand our knowledge of who people and families affected by drugs are and how they function. And there's further optimism that we can tailor treatment and intervention to the individual and then work to change some of the attitudes over time, eliminate stigma, but none of that is simple. Now the next slide, please. So this is a map of the whole Lothians area, and it's superimposed the multiple deprivation index. I've put the map really to reflect the challenge for implementation by colleagues across Lothian. They face specific local issues. If we superimposed sites of non-fatal overdose or unstable housing, hostile accommodation or other factors, we can identify and start to better target responses and interventions. So the same thing is not needed or possible in all the respective areas. Case mix is different, often as primary care input varies considerably. The respective ORT models need to reflect this. Of course, services across Lothian have developed differently, are commissioned in disparate ways, with third sector health and social care partners doing things differently based on local needs. This poses challenges for prescriber cover, for overarching clinical governance, for IEP, for skill mix and workforce development, for community pharmacy coverage, and for ensuring fit for purpose premises to deliver all the expected care and treatment. The next slide, please. For those of you who don't know, this is a place in northwest Edinburgh. It's the Recovery Hub. It's right next door to the Western General Hospital. It's got Lothian's biggest primary care ORT providing GP practice down the road, several community pharmacies around the corner, and a social work hub nearby. And it's here a quarter of Edinburgh's outpatient mental health, NHS addictions, third sector, CGL, and social care teams are based. Except in this picture, which is taken in working hours, there's no one in the waiting room, and we've had to find new ways to do our work. It would normally be jam-packed, busy nurses, full waiting room, clinics, treatment, naloxone, third sector colleagues, social workers, and ongoing groups. But it's all changed. And remote working and digital environments have provided for some non-urgent care, and it's meant continuity. And I think reasonable quality for psychosocial interventions has been maintained. But what about groups, and what about peer support? The entire workforce adapted and accepted the challenge faced when COVID came along, and our patients with addictions needed that help to ensure continuity of treatment and to ensure previous and entirely new patients could come and get help. Overnight, the rules around ORT were relaxed, and that's shown in the graph to the right. Longer pickups and reduced supervisions to reduce travel and trips and exposure. And the graph shows the percentage with at least part of the prescription being supervised. It went from around 75% pre-COVID to 30% post. And we know it was probably even less than this as community sites were struggling to cope. Over time, it's increased slightly again, nearer 40%, but nowhere like pre-COVID levels. And we can't see that ever being the case again. I guess we don't know what will happen over time as a result of this. It's been good for some people, but for others, more methadone at home may be more risky, especially if pharmacist and key worker and other support has reduced as well. These risks need weighed up at operational and policy level. I want to make a case that the supervision budget is retained and recycled into the treatment system. It means resource for getting help to more people. And we found new patients as well, not hundreds, but many. Same day in-person and self-assessment and ORT starts with creative follow-up plans and other support built in, and not just for people coming back to treatment, but for new people too. The existing caseload was retained and added to by more than 100 between March and September. The digital transformation has encouraged more liaison with wider colleagues. One example is around community pharmacy. We're getting early heads up And we've managed some restarts without any other appointments to avoid dropout. There's also been a psychiatric hospital addiction liaison team set up to address drug and alcohol treatment needs for inpatients there as well. Next slide, please. Thank you. And finally, injectable buprenorphine clinics. So it's a new treatment with new opportunities, new outcome measuring, and new service delivery challenges. And it's been established intra-pandemic. But these are good challenges to have as people are optimistic and enthusiastic about having this as a new treatment option. You can see our Northwest clinic numbers increasing each clinic week. And like everywhere else, we've got a task to build more capacity around this. So I'd conclude by hoping that the anxiety-provoking COVID-required service changes could act as templates for any MAT standards-related changes. And there are challenges, but implementation of multiple parts, all with the aim of saving lives, shouldn't be insurmountable. Thanks.
Thank you very much, Mike. That was a very helpful presentation, providing useful insight into the issues around effective implementation and the issues particularly facing Lothian. I'll move on now to our final speaker, Saket Priyadashi, who's last but not least. Thanks, Saket.
Thank you, Dave, and how did I know that was going to be your introduction there? I'm really grateful for the invitation to speak today. I'm also very grateful to the 369 attendees who are still in attendance. That shows the level of interest in this work and the importance, I think, of this work. What I would like to do is just quickly to give my perspective on the opportunity that lie in the implementation of MAT standards. I'm going to quickly describe some of the work that we've been doing in Glasgow that is very aligned to the aims of the MAT standards. But then I want to take a few minutes at the end to really reflect on, and I think we need to do this, some of the challenges that lie ahead in the successful implementation of the standards. Next slide, please. But I do want to begin with a confession, and this is a confession particularly to Duncan, Eleanor, Tracy, Dave, and others, to say that at the start of this process and my involvement in the MAT subgroup, a part of me was very excited about the project that we were embarking upon, but another part of me felt a bit like Phil here, you know, the middle-aged man who easily seethes with rage at any slight, and the slight really was, are we going to start about another reinvention of the wheel? I firmly believe in the evidence base of medication-assisted treatment services, but I understand that the implementation hasn't really met the standards that we'd wanted before. And I was a bit worried that we'd focus too much on the evidence, but through Duncan's leadership, Eleanor's expertise, Tracy's enthusiasm, and the work of the subgroup, I think we've really developed, next slide please, MAT standards that really take the evidence base and help services implement and get effective outcomes for that evidence base. Outcomes that will lead to increased access for service users, improved quality of service and experience for people who use drugs in treatment, and then, of course, increased individual recovery outcomes and population level outcomes, which includes, of course, hopefully in the long term, not too far in the long term, a reduction in drug-related deaths. So I consider this development of the MAT standards as a real milestone, as Dave described in the drug service and drug policy in Scotland. Next slide. So one of the hopes I have that this standard will do is deliver a higher number of people in treatment, a greater coverage of the at-risk population in treatment services. And as you heard from some of the testimonies of people with lived experience, people who are waiting for treatment, if they wait too long, then they're more likely to end up in prisons, in hospitals, and unfortunately for many, in the mortuary. And that's why we really need to prioritize access to services. Unlike, well, the shoppers who are waiting here for the shops to open on Friday morning at 9 a.m. on the 27th of November, a date still called Black Friday, despite this being 2020, they know the shops will open and they know when, but our service users are left with uncertainty, with a sense of rejection, and with that comes a whole degree of risks. We really need to get treatment coverage well above 50% across Scotland, as well as providing a consistent service across Scotland. Next slide, please. But there are ways that we can engage with people who feel they have been rejected, who have left treatment services, and who are, in apostrophes, hard to engage. So despite the COVID pandemic in Glasgow City, we've been increasing our street outreach. We have taken homeless health services away from Hunter Street, which is our main office space, into where drug users, people who use drugs are more likely to be found and more likely to engage, such as hotels. We have worked assertively with the data from emergency departments to try and identify people who are presenting with near fatal overdoses and to follow them up. And this has led to quite a remarkable increase in the number of people initiated onto opiate replacement therapy, despite the restrictions and the challenges of the COVID pandemic. And in that time, we've actually found a whole group of new people who are entering treatment for the first time. And that's a really positive development for us and shows that what is the art of the possible when we are really pushed into doing this. Next slide, please. The Minister said at the start, the Minister said at the start that he hoped to achieve a greater consistency of service across Scotland. And actually, that's required even in localities such as Glasgow City. So during the COVID pandemic, we really prioritised new patient services for opiate starts. And we wanted to measure how we were doing in relation to time onto treatment, and it's really the red figures that you need to see on this graph. So this work was led by our lead clinician, Gina Ritchie, and she shared the table with me. So you can see that in our 4 treatment services in the Glasgow City, most people are getting in treatment within 8 days, which is great, but actually only 2 of our teams were able to consistently meet people's needs to enter treatment within 24 hours, and 2 of our teams were unable to do that. So what we did was we took the learning from the systems and the practice in the 2 teams that were delivering well, and we spread that out into the other teams by, next slide please, by creating a standard operating procedure for new patient initiation and restarts of opiate substitute treatment. And this is very much aligned to the Drug Death Task Force initiatives and the MAT standards, and of course informed by what we know from the evidence base, including the recent Staying Alive report by the Scottish Drug Forum. Next slide, please. We also know that choice will help us attract and retain people in treatment, and I absolutely support the MAT standard about choice. But unfortunately, in the addiction field, and particularly in the drug treatment field, we don't have a shelf full of therapeutic options, evidence-based therapeutic options to offer people. Methadone has been the mainstay of treatment for many years. We've added oral buprenorphine in recent years. But next slide, please. We have recently, as Mike and others have said, had the opportunity to try offering depot buprenorphine at the moment in the form of Buvidal. And this small audit of 32 new OST starts from our South Glasgow community team shows that actually by offering Buvidal along with methadone and buprenorphine, we were able to attract 32 new patients during June and July, despite this being the COVID pandemic time. And actually 8 of them were new starts. And of the new first-time treatment patients, 7 chose Buvidal. And out of people who are restarting treatment, 9 of them chose to go on Buvidal rather than back on methadone or buprenorphine. And I think that says to me that Buvidal has a real key role in widening our treatment offer to attract new patients and bring treatment and patients back into treatment. Of course, the COVID pandemic times meant that service users did not want to go to pharmacies as much as perhaps would be normally required with new ORT starts, and then that would influence the judgment to start buprenorphine. But it is something that we need to really keep in mind as we go forward. Next slide, please. But with choice, there's also an importance that we recognise people's rights, that we consent people in an informed way, with a Montgomery compliant way. And in Glasgow, I'm not able to display a whole range of other work that's going on, but these include things like we are funding a Glasgow Alcohol and Drug Recovery Services advocacy project for service users who are able to then have a voice within alcohol and drug services, as well with the whole range of other supports that they need, including housing and welfare rights and other things. So I'm not able to cover those, but so I wanted to just though end by focusing on one or two, I think, key challenges that we need to acknowledge and reflect on. And this is said in the spirit of perhaps a discussion that needs to follow this and the call that comes as part of the consultation process. So alcohol and drug services in particular are almost as stigmatized and as blamed as our service users are for some of the issues that arise in Scotland at the moment, and particularly for drug-related deaths. Our workforce, many of them who've chosen and dedicated their professional lives to working in this area and to improving the lives of the people that they work with, are often blamed and shamed, and they suffer the vicarious trauma of all the harms that we are aware of that happens in our service users. And so as we move on, I think we really do need to recognize that and have a positive discussion about the role of treatment and support our staff as we move forward. This image here is from a therapy room in the new Simon Community Access Hub in the Glasgow city centre. This is a room in which you can imagine the quality of conversation and therapeutic relationships that can arise from it are going to lead to quality outcomes for service users. I'm not aware of any such room in our drug treatment services, and I've been to some out with Glasgow and in other areas. It's psychologically informed, it's well resourced. So I would say to political leaders, I would say to Scottish Government, ADPs and health boards, that please be positive in your support of the treatment services, positive in your support of staff, and give staff the resources that they need to deliver these services. Now, as well as these resources, what staff want most, I think, is time with service users. And that means reduced caseload. So I think we need to see a significant expansion of capacity in our services as well, if we're going to both improve access and improve quality. Final slide, please. And as I've been discussing with Duncan and Eleanor, I'd like us to consider now at this stage what success really looks like. Of course, success in the long term means a reduction in drug-related deaths and reduction in drug-related harms. It means improved access to services and improved quality of those services. But we need to measure the steps that Duncan and Eleanor showed in that ladder. We need to measure our journey up that ladder, and we need to be mindful that when we're doing that we have smart, realistic measurements along the way, and ones that aren't putting the onus on our frontline staff and adds to the burden of work that they have to do. So in conclusion, I'm delighted with the MAT standards. I think there's a real opportunity here for us to have very significant improvement in our treatment services. And I would say that we need the support, our staff need the support and leadership and resources to deliver the aspirations of the MAT standards. Thank you very much.
Thank you so much, Saket. That was a very insightful overview of the importance of implementation and some very important points that you made at the end there. Thanks again for that. That was great. Now we're coming towards the end of the webinar. I just want to bring Eleanor back in briefly just to talk about the next stages of the consultation, and then we'll conclude. So over to you, Eleanor.
Thanks very much, Dave. So I hope that's given you a flavour. This work is brought to you as a collaborative piece. It's brought to you as a work in progress. The body of work is the standards that we've outlined, and the consultation is on those, and also the work that Tracy outlined, which has been implementing and innovating around the standards. We've heard from a number of colleagues from around the country, and so we hope that the standards are meeting the treatment system needs. But we need to hear from you, and so we're embarking on a suite of events. We have some workshops which will be shared just after this webinar on standards 1 to 5 in the next fortnight, that you can sign up for workshops that the Scottish Drugs Forum are leading on. Then next week we will have some dates released for workshops on standards 6 to 10, and we're working with specialist agencies across those standards, so the lead psychologists, NHS Education for Scotland, the Royal College of GPs, and advocacy agencies, Advocard and others from Scotland, to really lead some development work around those standards. As we've said, it's a work in progress, and you'll see this is reflected in the document. We have detailed some key requirements against each of the standards as we currently see them, and we're looking for additional aspects that you require to deliver the standard in your service and in your local area. And as Saket's just detailed there, we're particularly keen to also understand what examples of evidence and measures in terms of actually demonstrating progress against the standards. And we'll be looking at bringing a body of work around the measures and looking at an independent assessment framework to accompany the standards over the course of the next few months. So all of this process will inform the work plan over the next 18 months to 2 years, and we're working with Healthcare Improvement Scotland around the support that we can offer as a programme team in terms of developing the innovation and ensuring the sustainability of these standards. The consultation period in the immediate term is until the end of January, and we anticipate reporting hopefully in March, at least in an interim, in terms of what that has brought, and as I say, the work plan going forwards. So please get in touch with anybody on this webinar. Tracy gave her email, and or you can contact phs.drugsteam@phs.scot, and that will come to myself and colleagues, and we'll get back to you. Even if it's just to ask for the calendar of events, please get in touch, or if you'd like us to join your networks or groups, please, we're looking for new opportunities. We've got these events that we've scheduled. And the last thing to say is there is an online survey. So if you want to apply as an individual, either from your service or from your network, we've also offered that process. So hopefully there'll be different ways that you can get involved. I've just seen the time, Dave, so I'll hand back to you.
That's great. Thanks, Eleanor. Yep, we've run out of time, but we've pretty much kept to time, which is great. So we've come to the end of the webinar, but this has been recorded and will be published on the SDF YouTube channel on Monday. You'll receive an email that includes, as Eleanor says, details of the workshops and the online survey that will support the consultation. Just maybe one thing to add, that please note the workshops are designed for people resident in Scotland only. And finally, I'd like to thank you all for attending, and a special thanks to today's speakers, and thanks for successfully launching the consultation. We hope that everyone will participate in the consultations and encourage other stakeholders to do so as well. So thank you very much for attending, and goodbye for now. Thank you.